I'm the Suicide Prevention Coordinator out at the St. Cloud VA, and I am so very grateful to be here tonight and to be able to bring this presentation to you. Some of you may have heard many of these things before, but some of this might be new, and my hope is that everybody will take one thing out of here with them that they haven't heard before and utilize it in your community and with other veterans or in your homes. So, and I have a resource table there, and everything is free for the taking. So feel free to walk on over there later, and if you have any questions, we'll move forward with that as well. With me, I have Jonathan Law. He is one of our chaplains at the VA. He's also a chaplain with the reserves, right? The Army Reserves. Yeah, and so he's active with that as well. And I'm very pleased to have him here with me because there's things that he can present, and there's a section on moral injuries that maybe a lot of people haven't heard about, but it's very, very valuable information to know because it often is what keeps people stuck in their illness and what needs to be addressed along the way in order for people to actually heal beyond the educational piece. So with that, we'll just get started a little bit. We're here for an hour and a half, but we're hoping to have a time for Q&A at the end. Okay. Any questions up to this point? Some of the things that we're going to do along the way here, and we'll be talking a little bit about the statistics and the background of the program and about suicide prevention. We'll look at risk factors, warning signs, protective factors, how to ask the question about suicide, how to even know when you need to ask the question. Examples, we're not doing the examples in practice with this, but we are also going to talk about moral injuries along the way. And along with that self-care need, the need for all of us to do some self-care. Because if we can't take care of ourselves, we're not going to be able to care for somebody else. So why talk about suicide? Well, we want to improve the ability of to identify risk factors. We want to improve your knowledge and help decrease stigma. That stigma that surrounds mental health conditions is oftentimes what keeps people getting the help that they need. In our country, and not just within the VA, but VA is actually probably more progressive about this than other people, but in our country, we still have this stigma about mental health. People feel like they should be able to control it, pull up their bootstraps, and get on with their life. But the reality is that mental health conditions are medical conditions. They're the conditions of our brain, just like diabetes is a condition of our pancreas, okay? And that's a medical condition. Heart disease, a condition either of our kidneys or our heart that causes high blood pressure. These are things that are medical conditions. And mental health conditions and addictions are conditions of our brain, and that's just another organ. So when somebody dies from suicide, they're dying from an illness. It's a mental illness perhaps, but it's an illness, okay? They didn't ask for it, no more than somebody would ask for cancer or a broken leg. They didn't ask for it. They died from an illness, whether that's depression, PTSD, anxiety disorders, or a substance use addiction, okay? Does that make sense to people? Okay, if it doesn't, if anything I say doesn't make sense, please feel free to ask for clarity, okay? All right. So worldwide, over 800,000 people die from suicide each year. In Minnesota, more than 700 last year died from suicide. I think it was like 748 in the state of Minnesota. Nationally, there's about 44,000 people that die from suicide every single year. Okay, 50% of those that die from suicide across our country do so with a firearm. Okay, so and veterans are more likely to use a firearm. So that's why we have the Gun Lock Initiative. And that's why I'm so grateful for the American Legion and the VFW to partner with us with this initiative to get those gun locks in the homes of anyone that has firearms. We are not about gun control. We don't want to control people's firearms. Everybody has a right to bear arms in this country. But we want to help people stay safe. We want households that have firearms to be safe, because we know if we can decrease the access to the most lethal means, then we can help save lives. So 68% of individuals in our country that are veterans in our country that die from suicide do so with a firearm. And in our central Minnesota area last year, in our St. Cloud catchment area, which covers 27 counties, 76% of the veterans that died from suicide last year did so with a firearm. Now, 50 years old is the mean age for suicide. 50 years old. You hear, oftentimes we'll hear that the younger population, that 29 to 55-year-old, they're a higher rate of suicides. Per capita, per age, yes, that you're going to see an increase there. But reality is that age 50 is the mean age for suicide. Of those veterans that died last year via the St. Cloud VA in our catchment area, 14 of them were 76 to 92 years old. 70 to 96 years old. So that tells you there's a population there that we need to really consider. Okay. These veterans, 13 of them had never been seen anywhere in mental health. They were strictly seen in primary care, but they had symptoms, they had conditions, like medical conditions that put them in a place where their life could end because of their medical conditions. But they chose to end their life by suicide rather than deal with some of that, okay? Because they saw what would be happening. They may have been losing their independence. They may have been losing some of their financial finances. Their medical conditions decreased their mobility. There's a lot of risk factors that were there that weren't necessarily related to a mental health condition. So we have to pay attention to risk factors that aren't necessarily related to mental health. It might not be related to a depression or an anxiety disorder or PTSD, but there might be other conditions. Other methods that people use, 24% nationally will use suffocation or hanging. There are poisonings, cutting, and then drowning, 1%. And the reason we focus so much on the firearms is that 90% of the people that use a firearm to attempt suicide will die. You can't undo that bullet once that trigger is pulled. You can't pull it back. If we can get a gun lock on those firearms, it allows time and opportunity for that person to change their mind or for somebody else to intervene. An example of this is a veteran that a few years ago I had worked with, and he did put gun locks on his guns. And then his wife left him and moved to Tennessee, and he basically had a phone call with her, and he said, "I'll see you on the other side." She had a health and welfare check called to their home, and this was actually in Cambridge. And when the police arrived, he was in the process of cutting off the gun locks. The gun locks saved his life because it took time and opportunity, gave time for that police to get there before he could get to the trigger and get the bullets and everything. So, and all the other means that somebody might use to end their life, again, allows for time and opportunity for rescue. Approximately 20% of the deaths by suicide are veterans. There are over 120 deaths a day from suicide, and 20% of them are veterans. About 20 veterans a day. Of that 20, 14 of them have never touched a VA. So that's another thing that we want to do. We want to get people connected. And if we can't get them connected right away, we can get them into community agencies. There are community resources. There are other veteran resources that are available that can help people get some help when they need that until we can get them stabilized. But we have the resources to do that. Statistically, in a study that was done over a period from 2001 to 2014, it shows that veterans that get care within the VA health care system are less likely to engage in suicide. And female veterans are, the rates have gone up dramatically in comparison to the past. And those female veterans that are not getting care in the VA, their suicide rate went up by 98%. But the ones that get their care within the VA, it increased by 4%. So there's a dramatic difference between veterans getting care in the VA healthcare system and those not. Every 12.3 minutes, someone dies from suicide. It is estimated that close to 1 million people make a suicide attempt each year. One attempt every 35 seconds. Now, that's not the veteran, that's generally speaking. One attempt every 35 seconds. Just think how long we're going to sit here, how long we're going to be in this room, and how many people will die, and how many people will attempt suicide. So there is gender disparities. Men generally die more from suicide than women. Women will attempt more. Women attempt 3 times more than men, but men die 4 times more than women. Okay. This slide shows the state of Minnesota, and it shows that, again, it shows the rate of suicide nationally, and then the rate of suicide in Minnesota. So the numbers in Minnesota was 730. And this was in, I think it was like 2014. So those numbers have increased each year. 44,000 last year, or that was the last time this was done. When we look at statistics regarding suicide, they're usually a couple years behind because it takes that long for the Center for Disease Control to get all the data from the states. So that's why when we look at statistics, they're generally a couple years behind. Okay. So again, this slide is showing that older adults, 65 and older, are at greatest risk. Adolescents, young adults, Caucasian, Native Americans, veterans are on there, people with mental illness, men, and police. And I would just add with that police, first responders in general. You know, that could be our EMS as well. And I'll let Jonathan talk about some of this and the next couple of slides.
Yeah, so these numbers are also from 2014. So in 2014, there were 269 suicides in the active component and 169 in the reserve service. So a total of 1,126 suicide attempts. And the highest number is in the Army. Air Force 13%, Army almost 28%, Marine Corps and Navy are 8 and 12%. And the reserves and the National Guard make up 18 and 20% of those numbers. So there's actually no active duty bases here in Minnesota. We've got a lot of Guard units. From 2007 to 2011, the Minnesota Guard had the highest suicide deaths among all states. Well, it's not a statistic that we want to brag about, but I think we have a lot of Guard members in this state. In 12 to 16, they were the second highest deaths in the entire country. And in 2016, there was more suicide attempts for non-deployed soldiers than deployed soldiers. So I guess why it's so important we're here is Minnesota, I mean, just like any other state, struggles with suicide. And a lot, it could base on a whole bunch of different items, but a lot of it has to do with the way, like without having an active duty post, soldiers they don't go from overseas to right back to the active duty base where all the resources are right there in front of them. They come back and they're connected to the local resources, the local VAs. It's just a little more of a transition and it's a little more difficult. But the numbers are high, so we wanted to put that out. If you look at this slide right here, it says that active duty and Guard Reserve. So more likely to encounter a National Guard or Reserve veteran in Minnesota. Like if you're going through Minnesota, you're more than likely to encounter a National Guard or a reservist. And they often do not have as strong of a bond as they do with their fellow active duty members as when on active duty. On active duty, you have a strong bond with your squad. You see them every single day. That camaraderie it weighs a lot.
Okay. Well, when we're dealing with a family member that, because first of all, there are a lot of families that'll call the Veterans Crisis Line, okay? Because they're concerned about a loved one. They don't know where to go, what to do. That crisis line sends a consult on to us. We follow up with that family. We help them get help for their loved one. If they're enrolled in the VA, they can bring them to the VA. We tell them to bring. We contact our veteran service officers. We may, because we want to help get them the care that they need. So we want to establish eligibility. We want to be able to get them the VA services because we got services. We have services within the VA, but maybe there's Lutheran Social Services. That's another agency the VA contracts with, and they will do therapies for these individuals. They have financial support. There's a lot of things within Lutheran Social Services. Sometimes if veterans are with the National Guard and they don't want to come to the VA because the VA might access their records and they don't want to get mental health help. Well, then there's other agencies. There's like the vet centers. We have referred people to the vet centers, whether it's here or whether we don't have one right here in St. Cloud and in this area, but there's one in Duluth. Brooklyn Park is probably the closest, and then there's St. Paul. So the vet centers, there's Give an Hour. There's a resiliency project where they will send a therapist out to that veteran. There's Military One Source. So we tap into whatever we need to get the help for that person. And if it's an immediate situation, we will have them directed to the local hospital and the emergency room. If there's an immediate warning sign or an immediate need for somebody to have help right now. If it's not an emergent situation, and this is things that can be we'll get these other sources in place. This slide, okay, violence prevention is suicide prevention. So violence, whether it's intimate partner violence, whether it's military sexual trauma, violence prevention is suicide prevention. There was when QPR started, which is a model for suicide prevention, it started in the 1990s. And they implemented it with the Air Force. Okay, and it was one of the first models for suicide prevention that was put out. They implemented that with the Air Force. Not only did their suicide rates go down, but they were surprisingly found that their domestic violence rates went down as well. So what we found over the years is that violence prevention is suicide prevention, helping people that are struggling with anger issues and violent tendencies. We're doing suicide prevention. Domestic violent people make more suicide attempts. People that are domestic are perpetrators. Violent families contribute to the youth suicides. Think about that. If a youth is living with somebody that's violent, they're more likely to die by suicide. Violent people have a history of self-destructive behavior. Okay, you think of murder, suicides. Okay, they're more likely to die from suicide if there's violence in the home, whether it's domestic violence or other forms of violence. Okay. There's double suicides, you know, like, it could be a wife and a spouse, could be a spouse to a wife, or a wife to a husband. There's that murder-suicide. Males who threaten suicide in an intimate partner violence situation are at greater risk for murder-suicide. And I think you hear that in the news all the time. Still hear that. It's not, that's validating. But we do know that violence prevention is suicide prevention. Now, all the VAs now have an intimate partner violence coordinator. Joy Finkelson is not only the St. Cloud VA intimate partner violence coordinator, but she's also our military sexual trauma coordinator. Sometimes veterans have military sexual trauma, and that can be an all-out assault that they might have experienced, or maybe even there's evidence of ongoing sexual harassment. And the VA will treat somebody with military sexual trauma even if they're not eligible for any other care. They can get care for military sexual trauma. So the VSOs can help with that, as well as contacting Joy, and she can help navigate the system. So that's Joy Finkelson at the St. Cloud VA. Alcohol abuse and suicide. Not going to go through every single one of these, but I'll just tell you the impact that alcohol has on suicide is astronomical. People that would never consider suicide in a sober state will go there when they're drinking or using substances. Alcohol breaks down every protective factor that somebody might have. People might say, I have my children, I have my spouse, I have my church, I have my friends, my pets. I have a lot of reasons to live. But when alcohol gets on board, all those protective factors mean nothing. So when people think about, okay, this person has all these reasons for living, if they're using alcohol, it doesn't matter. Those things go out the door. So just know that alcohol is tremendous impact negatively when it comes to suicide rates. Okay, here's some myths. A myth about suicide. People who talk about suicide don't mean it or don't do it. Well, the people who talk about it, and if we can let them talk about it in a very calm, matter-of-fact way, it decreases their risk. It decreases the anxiety because they want to talk about it. And by allowing them to talk about it, only helps them. It can give them that little bit of grain of hope that somebody cares, somebody's on my side, and they're going to get through this. Okay? So allow somebody to talk about it. Talk about what's going on. We have 2 ears and 1 mouth. God gave us those things. But that means we listen more than we talk. Okay? And that listening can save a life. Just listening, hearing their story can save that life. Make them want to live. Okay. Next one is no one can stop a suicide. It's inevitable. Suicide is one of the most preventable causes of death. Now, are we going to save every life? Probably not, but we still have a goal that we want to do that. 0 suicide is still our goal, but chances are we're not going to save every life from those illnesses, no more than we'll save all the lives from a heart disease or something else. But we can decrease the suicides. It's one of the most preventable causes of death. Okay. Most suicides happen without warning. That's not true. Okay. Generally speaking, the person that ends their life will somehow communicate their intent within a week before. Now, that might not be, it might be that they'll say, oh yeah, I'm going to kill myself, but it might be something that's totally different. I feel like a burden to someone. I feel like a burden to my family, to society. Maybe they're doing things, there's behaviors like updating their will, writing a suicide note. stockpiling a means, like a weapon, seeking a weapon, stockpiling pills. Maybe there's other things that are going on. Maybe they were never interested in religion and all of a sudden they're interested in religion. Or maybe they were interested in religion and are pulling back from religion. Those might be things that say they're preparing to meet their maker. So people generally will convey their intent sometime within the week before. So it's us being prepared to recognize those signs. Recognize somebody that's struggling emotionally, whether that be maybe they're more agitated, angry, irritable, feeling hopeless, helpless. Maybe they're not, they don't have that purpose. Maybe they're not taking care of themselves like they used to. You know, maybe they're not eating right, sleeping right, okay? Maybe they're isolating more, okay? Before they were more social, and now they're isolating. Things like that tell us that these people are hurting. Doesn't mean that they're actively suicidal and that they're at imminent risk, but it tells us that they may need some help. And we can be there. You don't have to be a psychiatrist. You don't have to be a social worker or a therapist to be there for somebody that's hurting. And that's all you need to do is be willing to be there. I see a lot of our guys here that are volunteering at the VA. Leroy's there and some of these other fellows with the Marines and Marine Corps League. And, you know, they're at the VA. We see them there. They're there for our veterans all the time. And sometimes that's all it takes is just somebody being there. Being there to just say, I'm on your side. You know, we're going to get through this. And we're going to help you. So, if you ask someone about suicide, it will give them the idea. How many people have heard that and believe that? Oftentimes that is a big myth, okay? And people that have like you oftentimes you'll see that in the school system. A school-age child will end their life. And the school doesn't want to talk about it because they're afraid of that contagion effect. People are either thinking about it or they're not thinking about it. By not talking about it, it actually increases the risk. People are hurting. And if somebody, their best friend, dies from suicide, all the more reason to talk about it. But that does not put that in their mind, okay? Talking about it doesn't put it in their mind. They've already either thinking about it or not. Risk factors. Like I said, there are these tangible events, behaviors that we just talked a lot about. There's that sense of hopelessness, helplessness, worthlessness. If people don't have a sense of purpose and they feel worthless, those are huge risk factors. Maybe writing a letter, maybe updating their will, those kind of things. Those are behaviors that might indicate somebody's thinking about it. The warning signs. There are direct warning signs and indirect warning signs. Protective factors are those things that keep people alive. Those are the things that reduce those risks. But just know that all of those things are only dependent on sobriety. Behavioral health issues, and we talked about that a little earlier. You know, there are mental illnesses, but those are illnesses, and they're illnesses of our brain. There are other individual characteristics, and those might be people, other medical conditions. Maybe people losing their home, or that loss of finances. Maybe that sense of burden. Maybe families moving away. Maybe they've lost someone close to them. Those are those individual characteristics that could heighten somebody's risk. Those stressful life circumstances. Family characteristics and community events. These are things that help us to recognize that somebody might be at risk. If you recognize somebody going through relationship issues, 75% can be the loss of an intimate partner relationship can increase suicide risk by as much as 75%. So just know that if somebody loses that intimate partner, whether that's through divorce, death, separation, that can increase their risk. Here are some other risk factors. A previous suicide attempt, being fired from a job, being expelled from school, our veterans returning from deployment or getting out of the military. They just have a sense that they don't fit in at home, they don't fit in at school, they don't fit in at work because things have changed for them. And the community doesn't change. They don't have the structure that they had in the military and that they were used to. Things have changed. They have a hard time figure out where they fit in. People with legal issues, that risk of incarceration can really increase somebody's risk. Recent unwanted move, that could be moving to a new community, or it could be maybe moving into a nursing home for somebody that's older. That loss of independence, loss of a major relationship, death of a spouse, a child, or a best friend, especially if it's by suicide. Communication stress, hard for people to communicate their mental health conditions. Sometimes they don't even recognize it themselves. But sometimes too, like I think of our veterans that have come back, it's hard for them to communicate what's going on within them. And families just want them to come back and be the same that they used to be. And they're not the same, The terminal illness, I think the most hardest time is when they're terminally ill, is when they first get diagnosed. Before they get to see that oncologist, before they get to see the person that's going to help them get through that, or the treatment. What's the treatment? I had a veteran that had experienced prostate cancer. He was diagnosed with prostate cancer, early prostate cancer. But in his mind, all he heard was the word cancer. And he felt his life was over. He hadn't seen the urologist yet. He hadn't seen him. Well, he had 2 very serious suicide attempts. And then he was admitted to our acute mental health unit. Well, in doing that, then we got him connected to a urologist while he was there. And he came back from that appointment, he was like a different man because he realized he could live with that for 20 or 30 years. And when he was first diagnosed, he realized, he thought it was just the end of his life. So he was going to make a choice. So that fear of becoming a burden. I had a female at NAMI, when I did a training there, she said, my grandmother killed herself. She never had any warning signs. There was no warning signs, nothing to suspect. All she just told us was that she was a burden. She felt like she was a burden. And we'd tell her she wasn't. But it was her perception that she was a burden to society and to her family. So if somebody is saying that, take it very seriously. Protective factors, I've discussed what they are. And there's so many, and what's a protective factor for you would maybe not be a protective factor for me. Everybody will have their own protective factors. But understand again, alcohol will break those down. I will let John take this one.
We kind of covered this in the beginning when we talked about the firearm lethal means.
Yeah.
I don't think it's anything new.
We don't call it lethal means reduction anymore. We're calling it lethal means safety. Because reduction tells veterans that we want to take away their guns. And we don't want to take away their guns. We want to just help them stay safe. So we've changing that language, even though you'll hear lethal means restriction, lethal means, okay. We've talked about these warning signs, okay. Substance abuse, hopelessness, reckless, that reckless behavior, drinking too much. I had one veteran that when he was drinking, he would jump off the 3rd floor balcony of his apartment to get that adrenaline rush that he used to have when he was in the military, when he was driving. So again, that was risky behaviors, mood changes. Sometimes people have mood disorders, and then when they drink, they stop taking their medicine because they're told not to drink with the medicine. So they stop taking the medicine so they can drink. So the mood disorders, feeling trapped and like there's no way out. People that are suicidal, they don't see suicide as a problem. They see suicide as a solution to all their other problems. They don't consider suicide a problem. So if we can help people solve their other problems, if that's what they're looking for, then we can help save lives. Because people that are that want to suicide do so because they have a lot of other problems. Things people say?
No one can help me, what's the use? If you hear that, it could mean a bunch of different things, but it's worth investigating. These are like warning signs that you really want to pay attention to. If you hear someone say, I wish I were dead, no one would miss me if I wasn't here, I just want to sleep, just go to sleep and not wake up. If I kill myself, then people will be sorry. That one's very obvious. My family will be better off without me.
These are things that people have said in that week before they ended their life or went on to make a suicide attempt. So just know that again, these are things that people will generally say something within the week before they attempt.
So now we're going to talk about asking about suicide. We're going to talk about when to ask, what to say, and how to say it. There's a lot of different things that go into this, but the main thing is when the risk factors become prevalent. The biggest thing is using your gut. When you hear phrases, when you hear people talking about like this phrases that we just listened to, you can get like, your gut's going to tell you, or you're going to feel anxious. There's just something that's going to say, I really need to. That's the second time I've heard this in the last 5 minutes. It's time to ask. It's time to investigate. When the warning signs are present, like what she was talking about earlier, when like dramatic changes in behavior, where they were once put together and all of a sudden now their hair's all messed up and they stop showering and like that's not the normal behavior of this person, I need to ask. And if you combine the verbal warning signs and then the physical warning signs, like you're gonna need to start asking those questions. And when risk outweighs protection, when especially when you start hearing about what used to be protection for them, what used to be supports in communities, and they're no longer a part of them, it's time to start investigating. The main thing is just use your gut and just listen. And the only way you're going to know when there's dramatic changes in behavior or attitudes or supports is if you know the person. If you really know who this person is. So, talk to your family members, talk to your employers, your employees, talk to your soldiers, because you need to know who this person is. And the more you know them, the better of an asset you will be in knowing when these risk factors are present. The verbal ones, a stranger could say that, and you get a clue. But if some of the signs are not as prevalent, and the more you know a person, then the more you're going to notice the changes that are less dramatic, but still worth investigating.
That might be somebody that had a job and they had their family together. All of a sudden they lose their job. Maybe their relationship breaks up. Maybe all of a sudden they're at risk for homelessness. All these, and maybe there are those that are diagnosed with medical conditions. These are not factors that say, okay, the person's not saying I'm going to kill myself, but they're risk factors. When you see risk factors, take them all seriously. Tips for asking the question: if in doubt, don't wait. Just ask the question and trust your gut. Your gut tells you that or if the hair isn't standing up on the back of your neck, it's telling you that somebody has to ask that question. And if you don't feel like you can, you find somebody who can, but trust your gut. If the person is reluctant to talk, just be a little persistent. Let them know why you're asking the question. Let them know why you're asking, because sometimes if they let them know that, hey, you're concerned, that's enough for them to start talking. Talk to the person alone in a private setting. Don't be walking out the door and then ask them the question, because you're not going to get a positive answer, because then you don't have the time. Give yourself plenty of time. Allow them to talk freely. Listen more than you speak. Have your resources handy. whatever that might be for that person. It might be a card to give them, the crisis line, but understand that if somebody has a really heightened level of distress, they're not going to be able to follow through on resources. You may need to take them to an appointment. Maybe you need to take them where they can get help. Okay. Just pay attention to where they are that time. You don't have to be the therapist. You just need to be there for them and help them get help. The question is, are you considering suicide? Or it might be, you know what, I listened to your story and you told me all these things and gee, that hurts me. I wonder if I were experiencing that, maybe I would have thought about ending my life. Have you ever thought about that? However that works for you, ask the question. And I would say when you leave here, practice with people. Practice getting that word out of your mouth, because sometimes that's a hard thing for people to ask. So if in doubt, ask that question, but be upfront with it and open with it.
So we'll practice real quick. I'm going to ask her about suicide and tell you an example of a way to not do it. And it sounds totally different.
Okay.
You're not thinking about suicide, are you?
No.
You see how that sounded other than direct? Are you thinking of killing yourself? Are you thinking of suicide?
And if he had asked me that way, I would have answered well, with everything that's going on, I probably would have. But he asked it the way he did. That's one way you don't want to ask it. Because when you ask it that way, the person's going to say no. Because they know that's what you want to hear. Or if you say, you wouldn't think about doing something stupid, would you? Or you wouldn't think about doing something crazy, would you? Well, if you do that, they're going to say no. Because if they were thinking about it, you just told them they're stupid or they're crazy. Yeah. And they know that you don't really want to hear what they have to say. So ask it right out. Okay? Particularly with men, they respond very well to that direct question.
I've seen soldiers, I've seen people, when you ask directly and you mean it, you will, I've seen their bodies just,
yep.
Thank you, because now you've given them permission to be intimate. It's a scary question to ask, and it's an incredibly intimate moment when you're talking about life and death with somebody. And so to be invited into that space, it can be a big deal. It means that you care. If you're able to go there and be direct, it means that you care about that person and you care about their well-being. Mm-hmm.
And they feel that. They really do feel that. And they really are that anxiety goes away, and they're so relieved that somebody gets it. So don't hesitate.
Another one is you're not thinking about hurting yourself, are you?
No. I'm not, but I might kill myself.
Because
there's a difference.
When people are thinking about suicide, sometimes when you ask them if they're thinking about they're not thinking about hurting themselves. They're thinking about taking all the pain away, so they can respond, "No, I'm not," and still be telling the truth, and you haven't really assessed how at risk they are. Does that make sense? So when you direct, there's no gray area. You either are or you're not. If you're not, they'll answer that, and it'll be a relief for both of you. If they are, then you can start working to get them safe. So
there's
it's important to be direct.
There's a difference between harming and killing.
Okay. Well, I'll do that. So,
yeah.
So I've noticed a lot of changes in you lately. Like you've been late to work a lot. You just don't seem like you normally are. You're not as happy anymore, like in your face. I saw you giving your stuff away. Like with those kind of behaviors, I started to get worried. Are you thinking of suicide?
Well, John, yeah, I really have been, and it's a struggle for me every day to get here, and I don't want to live anymore. I don't want to be there. I feel like nobody cares, and everybody would be better off without me. Yeah.
Thank you for sharing. Okay, so you see what I'm saying? Like there are ways to do it, but you just gotta be direct. Because if you beat around the bush and you talk about hurting yourselves, or are you really, really depressed? Like if there's enough warning signs that I named, just go and ask the question, and it means a lot. It means a lot to the person. That's true care right there. If you're willing to.
But if he had asked me, "You're not thinking about killing yourself, are you?" I would have said no. If he had said, "You're not doing," because I wouldn't have thought that he would have really cared. So I wouldn't have told him. But, if he's acknowledging the pain that I'm in, and he said, "Are you thinking of hurting yourself or killing yourself?" I will respond positively. But he's telling me just from his mannerisms that he cares. I care about you. Well, here's why I'm asking this. This is why I'm asking it. And sometimes just them knowing that you care and why you care, that might be enough for let them talk about it. But that's a really good question. And because then your gut's probably going to tell you, oh, there's something more. So then that's where that be persistent, but not be pushy, but be persistent. But I would always tell people at that point,
This is
why I asked.
Yeah.
Why I'm asking.
What you don't want to do is be like, cool, and walk away. Like that's, if your gut's telling you to stay there and be with that person, like if it's not suicide, it's something bad that you should care about, so you're going to stick around and listen anyways. And you're going to keep listening until you can find out how to get this person help.
Some persons don't think of their spouse as supportive. So, they may not respond the same way to a spouse as they would to you. Or they don't want to worry that spouse, but yet you as their buddy may respond, they may respond differently to you. So not every situation is going to be, but I think getting other people involved puts safety nets under that person.
So for encountering military, there's some things you want to be aware of. I guess when you know the person you're talking to and you see the risks and risk signs and risk factors to be aware of if you know they're a veteran. So if you're not of the military, even if you are in the military, it's probably not the best idea to tell them that you understand, because there's probably no way you understand exactly what they're going through. Even if you've had similar events in your life, you're not going to have the exact same process and feelings and emotions. So to say you understand kind of minimizes their pain, and you don't want to do that. So especially with military, I would say try to avoid the I understand. So be honest, respectful, and assertive. I think the assertiveness piece will go even further with a military member. I think they'll respect that no nonsense, kind of directly to the point. And so you can start the conversation about asking about their service to calm them down. Mm-hmm. Either way, like we talked to before, the main thing is just keep a conversation, keep a dialogue with them until you're able to get them the help that they need.
And I think sometimes if you're like that, be honest, respectful, and assertive, okay? If you're honest with them, and you, rather than saying, I understand, and you don't understand, say, I don't understand everything you're going to, but I will listen to you. And I want you to tell me your story because I will try to understand. But be honest with them and don't tell them you understand when you don't understand. Just tell them, I don't quite understand, but I want to be there for you. Yeah.
So we talked about the importance of practicing how to say it. It is awkward. So when you practice, like I teach assist in the reserves, and it's a 2-day workshop, and we spend almost about 6 hours sitting in chairs, talking, doing interventions with each other, role playing, asking that question over and over again. Like it takes practice. It takes effort to ask that question because it's a powerful question. So it wouldn't be a bad idea to get with a friend, get with a coworker, do some training, and just practice asking that question.
It'll go a long ways for you.
It doesn't.
Comfort,
I don't think it
providing
gets any easier.
No.
It always raises my anxiety because it means a lot. But it is better. It comes out a lot easier when you've done it lots of times. So practice. Mm-hmm. So what to do when the answer is yes? Yeah. Remain calm. Listen more than you speak. That's very important, because if someone finally says yes, then it's going to start pouring. Like, the reason behind it is usually right there behind the yes. And if you start cutting them off and telling them what they need to do, and just kind of, or trying to fix it, yo, you don't need to do that, that's a bad idea. Like, yes, it's a bad idea. However, you need to let them express all that stuff that's in there.
If you get a yes, you're likely going to save a life that day.
Yes. Yeah. Do not argue. Maintain eye contact. Don't just try to walk up. You need to be there with them. What if they threaten you and say, if you tell anybody?
Never keep it a secret.
I like that answer.
Never keep it a secret. And just, again, if they threaten you, say, you know, like, I really care about you. I can't ignore this. And they might be mad as hell at you at that moment. But I'll tell you down the road, and this is just through experience, that mad does not stay. But I, for a long time, I have a veteran I have flagged right now, and he's madder than hell at me. Because he got this flag and he's high risk and we're following up with him. And that's okay, but he's alive. That's the thing. They said keep it as, don't tell anybody, then he could be out there dead if you don't tell anybody. So, yeah.
Well, your safety is important. Like, it's really hard to do a suicide intervention when your life is currently in danger. Like, you need to put some kind of, you need to be safe when you're doing this. It's hard to do intervention when someone is so inebriated or so on some kind of other substance where they can't even connect with you. Like, if your life's in danger and this is all over the place, but you know they're at risk, then that's what law enforcement's there for. That is what I mean. You've got to use your common sense, I guess. Like, you can't do an intervention when it's just not safe for anyone in that moment. Does that make sense? Okay. Well, we keep going.
What to say and what not to say. If they say no, explain. Tell them why. We've kind of gone over this. Tell them why you're asking. Offer them resources. Again, give them an opportunity to express more. If they say yes, listen. Give them your full attention. Remember, suicide's not the problem. Suicide's the solution to them. You can ask them if they have a plan. Okay? You can ask them if they have intention. But you don't, again, at that point, you're just wanting to get them some help. You're not the therapist, but you're determining if they're at risk, increased risk, imminent risk, if they need help right now. So you can ask them if they have a plan. You can offer hope. And offer hope in any way. What's hope for you is not what's hope for me. But so I can't tell you what hope is, but offer hope in any way that you can for that person. And a lot of times that's just listening, because that listening allows them to have a little bit of hope and know that somebody's on their side and we're going to get through this. Yeah, we have urgent care at the VA, but even 24 hours a day. And urgent care is open from 8 a.m. to 6 p.m. But in the mental health clinic, building 111, people can be seen 24/7. There's a red phone in the lobby. Pick up the red phone. Admissions is going to let them in, and they can be seen by the medical doctor of the day. And it's always good if family or friends come with them, because a lot of times the veteran doesn't tell them everything. So they need that explicit information, that outside information. So, okay. No, the crisis line is if you call the 1-800 number, okay, and then press 1, you're going to get to the Veterans Crisis Line. And then if there's an emergent situation, they will send out the troops to you. They will send out the police if there's an emergent situation. But people can go into the VA and be seen. Walk in the door in building 111, where that's the mental health clinic. There's a red phone in the lobby. You can walk in there or bring somebody in there, and then they can be seen. And they could be evaluated by the MOD, the doctor that's on call. That red phone in the lobby is there 24/7.
Okay, yeah, so there's the suicide prevention resources. So there's a national suicide prevention hotline that you can call 24/7 to talk to somebody if you yourself were at risk, or I've done it to where I've called it with a person and we agreed to call it and put them on speaker and we just both talk.
The 1-800 number is a national number. That's the National Suicide Prevention Lifeline. When veterans call or somebody's calling concerned about a veteran, they're prompted to push 1. And then that takes them directly to the VA crisis line. Okay. And otherwise, they can stay in this number if it's a veteran and get to the crisis line, but there's an added steps to it. But when veterans call this number, which is a national number, anybody can call that. Anybody can. When veterans call, they're prompted to push 1.
The question is, what is moral injury and why is it important? So let's take one event, right? So this is, we don't know exactly what happened, but you've got 2 medics and an injured soldier. And could I have prevented it? Why me? Can I save him? All these thoughts are going on in this one situation, okay? The definitions are these. These are 2 good definitions, one by Jonathan Shea. It says, moral injury is present when there has been a betrayal of what is morally correct by someone who holds legitimate authority and in a high-stakes situation. Perpetrating, failing to prevent, bearing witness to, or learning about acts that transgress deeply held moral beliefs and expectations. What do you think that means exactly? When in the act of carrying out a military order or an act, you're forced to do something that goes against your moral compass. So when a good definition from earlier today was when your mind says yes, but your heart says no. That's a really easy way to put it. When your mind says yes, but your heart says no. When you're doing something in your normal duties, when carrying out orders, but your heart says no, but your moral beliefs are against it, but you still do it because of the situation, the totality circumstances. Does that make sense? Like the battle between what you think is morally right and what you have to do in the course of battle. This is an easy summary of moral injury.
It's like if someone is brought up and to believe that it's against their integrity to kill or their religion to kill, but then they have to go to war and they have to kill, and they may kill a child. That there's this disconnect between the brain and the heart.
So we're going to keep talking, right? So what is morality? It's a difficult thing to define. But humans experience morality in 3 levels. So we define morality with our head, our thinking, our verbal reasoning, what the morals we learn from our folks, from our parents, our upbringing. We learn from our heart. Our heart tells us that our emotion, our physical sensations, our moral intuitions like our gut, and then the community, the relationships we have, group dynamics, the communities that we were raised in. So we adopt some of those morals as well. That makes it 3 big things: our heart, our head, and our community. That's where we develop our morality. So when soldiers do something that goes against their morals, but is the decision they made in the moment, so they can shatter the meanings that they've had, that they've carried close to their heart for, well, up to that point. Their core beliefs and values, like who am I, like is my character flawed now, how I view other people. Trust can be an issue. In the definition that Shea put out there, has like when someone in authority gives you an order that you must carry out, but it goes against your moral beliefs. Then you can have trust issues with authority, because you look at the authority as the one who made you violate that moral code that you have. You can shatter where you think you fit in this universe. Your spiritual being. I've heard people describe it as like they're separating from their spirit, like they're ripped away from their humanity. My expectations about the future can be shattered, and people can lose hope. Because if they find meaning and purpose in a lot of those areas, and then now they're questioning all because of an act, or an act of omission, it doesn't have to be something you commit. It could be something you watch happen but are not allowed to stop because of orders. So signs and symptoms of a moral injury. The big ones are shame, guilt, anger, contempt, and hatred. And that's feelings that don't go away. Moral beliefs about self or others. So when you hear a person beating themselves up a lot, when they shame themselves, when they're angry at themselves, they can talk about how much they hate themselves for what they did. They have spiritual struggle, and the biggest one that I see is issues with forgiveness. Not forgiveness like self-forgiveness, forgiving themselves. I know plenty of veterans who are fine at forgiving everyone around them, but they beat themselves up every day and they can't forgive themselves for violating their own moral beliefs. They have avoidant or self-destructive behaviors. More risk-taking, substance abuse is a big one. It's big because we see it. And active or passive self-harm. So passive self-harm is they just stop taking care of themselves. Alienation, social isolation, that happens a lot as well. Job, school, family, relational issues, a lot of relational dynamic issues are going to be present, and mental health disorders. These are some of the most prevalent that we see when someone who's struggling with a moral injury. So how can the clergy help? Helpful characteristics of a provider, which is mental health, clergy. It's important to have that rapport. It's going to be difficult for someone to open up about their moral beliefs and what they believe they violated if they don't have that rapport. It's not the first conversation you're going to have most of the time. Is I feel horrible about myself because I did this. I was raised this way and I did this. You got to have that rapport. And that takes a little bit, and it takes a different amount of time for everybody. So you got to have patience. Cultural competence balanced with not assuming you understand. Ignorance can be your best friend in this kind of relationship. Being curious, not knowing, not saying, well, I'm not even thinking you understand what they're going through. Just having them explain how they're feeling, what they're going through, can be big. Because they can close, isolation's a big part of it. So if you go somewhere or you assume something, assumptions can be dangerous, and they can just close back in, and they're not going to trust you anymore because of that peace with authority that they might be having. So it's very tricky. Willingness to ask the hard questions in a non-judgmental way. Willingness to live with the ambiguity, the comfort in discomfort. Comfort with discomfort, and state-of-the-art knowledge. I don't even know what that means. State-of-the-art knowledge. What do you think that means? I don't know. But the whole living with ambiguity, that's difficult for a lot of providers to do, a lot of chaplains to do, because you want what's best for your soldier, and you want them to be not in pain. You want to find ways to demonstrate love and hope, and in this kind of process, you've got to be okay to sit there in that for a while, because this is not a quick process. Knowing when to refer. So when mental health disorders are present, like I'm a mental health staff chaplain. I'm not a psychologist, so I don't know. Like I know some of the DSM-5. I can have ideas of when I think they're dealing with more than a spiritual distress issue, and when I see those things are present, I can refer. I know how to put in a consult, and I can refer. I can talk and find out what kind of mental health work they've done in the past. There's a huge collaboration between chaplaincy and mental health, just for that reason, because most of the time it's a joint effort. It's the spiritual care, pastoral care, and then it's the mental health care, it's the medication. Like all these things all go together to help with holistic care, where you're tending to the mind, the body, and the spirit. If you leave one of those out, you leave a gap where they can fall down. So it's the right handoff at the right time. Just because I'm referring to a mental health provider doesn't mean I stop seeing that person. I'll check with that person. I'll check with that veteran a couple days later. It's like, how's it going over there? And then the mental health provider might put them with a nutritionist. Like, we're all on the same team together, and we have to communicate. So I'm glad you brought that up. Like, it really is. It's usually a bunch of things together.
See, and the chaplain piece with mental health is I don't want to say it's brand new, but it's growing and newer than it ever has been, because in the past with the federal government and our therapists, they don't go to this spiritual place in the past. And with mental health and the chaplaincy coming in, people are getting more permission to go to that place of spirituality where they weren't able to before or never did. But it is a place where oftentimes people stay stuck in their illnesses because they didn't get that piece taken care of. So like John said, we need the psychiatrist who can prescribe medication. We need the mental health worker who can do therapy. We need the nutritionist. We need all the components of somebody to make this person well. It can't be one or the other.
Yeah, and the St. Cloud VA is doing a wonderful job with this holistic care piece. We got a grant this year for 4. I get 4. Well, the system gets the hospital's going to have 4 mental health second-year residents. So clinical pastoral education residents who have their MDiv, who've been a chaplain in a federal facility for already a year, are now going to be assigned to just the mental health. So the coverage is now the chaplain department has coverage in homeless outreach, in the RTP program, and addictions, and the acute ward. So the coverage is no longer an issue, which, I mean, a lot of times there's like 650 VA chaplains nationwide. That is not enough for coverage. Like, we need a lot more. Moral injury current treatment. So these are the two main treatments they're doing right now, and that's the prolonged exposure and the cognitive processing therapy. I'm not going to pretend like I know exactly what those are, because I'm not a clinician.
These are traditional. When we have people in our PTSD track, and these are not just the PTSD track, but even in dual diagnosis, people that have PTSD. These are the traditional secular trainings that people are given. Okay.
Yeah, and then the ones that are emerging are the adaptive disclosure, the impact of killing, and the ACT model of care, the acceptance commitment therapy.
But recognize when they're hurting and just be willing to be there. Just letting them know, here I am, I'm on your side. Whatever you need, I'll be there for you. And that's the biggest message. Let people know that not just the veterans, but anybody in your home, anybody that you notice might be struggling emotionally, just say, can I help? I want to be there for you, okay? That's sometimes all it takes, is just be there, be present in the moment to get them over that point of crisis. 25% of the people that have seriously attempted suicide have said from the time they thought about it to the time they engaged was 5 minutes. Another 47% say within an hour. They don't think about suicide a long time. Only 13% have thought about it for more than a day. So that impulsive piece is a big thing. So if we can stay with somebody when they're at that level of distress until they get to a place of calm and can start thinking more rationally, we can save a life. Those grief survivors of loss that have lost someone to suicide, that's like no other grief. And it goes on for years and years and years and years. So just asking them, how are you doing? That helps them, because a lot of people won't ask that because that person ended their life. So they, again, with that stigma, they don't ask. But if you want to talk to somebody, just ask them, because it's like, if you just ask them how they're doing, like John said, just say, how are you doing? You don't have to say, how are you doing since your son committed suicide? Or how are you doing since your husband committed suicide? Just ask them how they're doing since they died. Just like you would ask how they're doing if they died from cancer.